Hello, everyone. Thank you for the invitation to speak today. My name is Asim Maqbool. I'm a pediatric gastroenterologist at the Children's Hospital of Philadelphia. I have a background in feeding disorders in children. Today, I'll be speaking about the GI tract and neuromuscular disorders as pertaining to feeding and swallowing. I do not have any disclosures relevant to this presentation. The objectives of my talk are to provide an overview of feeding and swallowing disorders in children. I'll also discuss the indications for supplemental or exclusive enteral tube feeding, and I will close with some confounding variables that may be of interest. So I'm going to start talking about the GI tract from an anatomical and other impediments to feeding aspect. And feeding and swallowing, as you know, is a very complex process and mechanism that starts with chewing and then with the swallowing. And the first area where you may have anatomical impediments are actually even above the esophagus, where the tonsils and adenoids may be. And large tonsils and adenoids can impact feeding and swallowing. The upper esophageal sphincter is a complex muscle. It's actually, the sphincter is comprised of 3 muscles that work in coordination for feeding and swallowing. And at that level, you can have issues with feeding and swallowing as well. Communications that persist between the airway and the lungs, such as a tracheoesophageal fistula and esophageal atresia, may present with feeding and swallowing issues very early in life. Vascular rings from the heart around the esophagus may also cause issues with feeding and swallowing, particularly with solids over liquids. This is a theme that you will see more commonly, and this may not present immediately, but may present when you start moving towards complementary foods. This is also a dynamic process, so this can present itself later in life as you may have loss of function. Other impediments to feeding that are very common across the board are issues such as gastroesophageal reflux, which is the effortless regurgitation of stomach contents up the esophagus. The acidity seems to do the damage, in which you can have inflammation related to that. Food allergy can also overlap with food reflux, with reflux esophagitis, and can present with inflammation in the esophagus. And then infections of the esophagus are possible, particularly if you're on inhaled steroids or swallowed steroids for other indications. Hiatal hernia is when the stomach outpouches from and is not in the abdomen, but enters the thoracic cavity. This can happen in chronic lung disease, for example, and when you have hyperinflation of the lungs, and it makes reflux more easy. Reflux classically is described as having more difficulty with liquids over solids and usually presents at a younger age than upper esophageal sphincter disorders do. Gastroesophageal reflux is most likely underdiagnosed in patients with neuromuscular disorders because they cannot complain of reflux, and then the posture and positioning also make a difference. Gastroesophageal reflux and the inflammation caused by it can be progressive, so we have to keep our eyes on this. In terms of motor abnormalities of the esophagus, pointing to the upper esophageal sphincter, with repeat swallows, you can exhaust that upper esophageal sphincter muscle, and then you can have what's known as a bar sign show up, as in this cartoon with a modified barium swallow study. So you can see this when you exhaust the sphincter in cricopharyngeal achalasia. You can see this in Cree-Duché or Russell-Silver syndromes most often. This may not be evident at birth and may present when you have transition to complementary feeds, as I discussed before, and you can have dysphagia to solids more so than to liquids. The treatment for this can be a myotomy, which is somewhat complicated. You can do pneumatic or bougie dilatations of the upper esophageal sphincter, and Botox injections have also been used for this condition. It's relatively uncommon, but we think about it frequently when we have issues with dysphagia to solids. Eosinophilic esophagitis is a food allergy-associated esophagitis most commonly. There is an overlap with gastroesophageal reflux. The picture on the left is an endoscopy picture looking from the mouth down towards the esophagus. And you can see these rings forming in the esophagus and some thickening and some furrowing, which are consistent with inflammation related to this condition. You can also sometimes see whitish plaques, which may relate to the inflammatory process. Oftentimes steroids are used for this process, and you can have a secondary fungal infection. So we're often cognizant of that. The pictures on the right are histology pictures showing eosinophils. And if you can see my pointer, there's an eosinophil or a more of a pinkish orange immune cell in this picture, and it shows up more prominently on the staining on the bottom picture. And the number of eosinophils you see on high-powered view are useful and indicative, and different centers use different cutoffs to describe the condition. Again, there's an overlap with acid reflux, and we try to help differentiate that to help move patients forward. Other impediments anatomically to feeding include gastric volume. A few children are born with small stomachs. Malrotation is a process by which, usually in development, the GI tract has a 270-degree rotation, and on the order of 1 in 500 people don't have this process either complete or it's incomplete, and that can present with anatomical obstructions that can be significant and sometimes life-threatening. Severe mesenteric artery syndrome is an interesting phenomenon in which if you lose weight quickly, right here at the third part of the duodenum, what will happen is you will have the fat pads on either side of that lumen dissolve. Behind that, you have the spine. In front of that, you have the severe mesenteric artery, and you can have partial compression. And patients can present with difficulty tolerating solids over liquids. They can be somewhat position dependent. And the therapy really is nutritional rehabilitation to help build up those fat pads back up. So we do see this not infrequently in patients who are immobile and who have sudden weight loss, say after a spinal fusion surgery, for example. These conditions may limit the volume of intake. And again, liquids are generally better tolerated than solids. Moving further down the GI tract, there may be other impediments that may present as such. Hirschsprung's disease is a condition where you're missing nerves in the plexus at the level of the anus. So the anus is sort of chronically, the rectal area is abnormal. You sort of have chronic contraction, and you have difficulty with passage of stool. Oftentimes children may not stool immediately in the neonatal period as age typical. They may strain to stool. They may have very thin pencil-like stool. And if they need assistance with stooling with digital manipulation, they may have a gush of air and squirting of stool that may present as such. In patients who have had abdominal surgery, they may have sometimes a blind loop or short bowel, a blind loop condition in which you have more bacterial overgrowth and gas that lead to abdominal distension and diarrhea. Short bowel syndrome happens usually following abdominal surgery, where you have resection of the intestine, such as in necrotizing enterocolitis, in which you have a shortened segment of anatomical bowel or functional bowel that can present with abnormalities with motility, with dysbiosis, with gas, etc. And these can also impede feeding. Usually these conditions are more evident at a younger age, but they can, and in younger patients and in smaller patients. But there are a number of cases of Hirschsprung's disease, for example. They may go missed for several years. Blind loop may not be obvious until several years after the initial surgery. And short bowel syndrome carries symptoms throughout childhood, but they can be managed and modified. There's some other factors that also limit appetite and intake that I think are important to discuss. Gastroesophageal reflux being a significant one, in which you have, again, effortless regurgitation of the stomach contents into the chest, into the esophagus, and sometimes into the mouth. The acidity is what causes the inflammation and irritation. And generally our medications that we use are aimed towards managing acidity. We don't talk about GI motility as much, but it does certainly play a role in managing refluxate. There are things we can do with diet, there are things that we can do with lifestyle, but there are medications that may also be helpful to manage the actual refluxate. Gastroparesis is by definition, a slowing down of stomach emptying. Some people generally have very slow GI tracts. The GI tract is a long neuromuscular tube, and conditions that affect other parts of the GI tract may also, of the body may also affect the GI tract. You can have acute on chronic worsening, certainly after a virus, and we see this very commonly, particularly in patients who are predisposed to this. Constipation can present with issues as well. Constipation is significant in limiting appetite and intake at any age, but certainly in smaller children and in younger children. And we describe this constipation as being not only hard stool, but the infrequent passage of stool. And the management generally relies on stool softeners, but sometimes you also need stimulant laxatives to help evacuate the stool. So again, this long neuromuscular tube has anatomical components to it, but it also has motility components to it. And sometimes we focus too much on one and not enough on the other. And I think sometimes it takes a combination approach to manage patients and to help move them forward. But all of these things can limit appetite and intake. The diet and digestion also make a difference. If you have a slower GI tract, certainly fat does slow down the GI tract somewhat, but we believe that fat is important as a nutritional source, as a source of fat-soluble vitamins and essential fat. So we try not to have very low-fat diets, but we also try to avoid having very low-fat diets. If you have a slow GI tract, we also try to avoid having high sugar content and high sugar intake, because that can impact intake and can also promote gas. We also try to match the osmolality as closely as we can with dietary composition. In terms of dysbiosis and small bowel bacterial overgrowth, there are certain conditions that may increase risk for this, including acid blocker use, slow GI motility. Again, sugars in the diet may be fermented more readily than more complex carbohydrates, and those can present with overgrowth. And constipation also can promote overgrowth. So when patients ask me, can we address dysbiosis and overgrowth, I always go back to the basics and I say, we need to modify these other risk factors before we start talking about antibiotics and probiotics, etc. Supplemental tube feeding. I know this is an important area of interest and a lot of people wrestle with this. But when do we talk about tube feeding? We talk about tube feeding when you have inadequate oral intake to meet your needs, number one. And number two, when safety of swallow is of concern. And you can have both of these that may present with a child, or you may have none of these. Sometimes you just have very food selective patients who will not be able to get their nutrition in any other way. And sometimes we have to navigate and negotiate these challenges. Tube feeding is not a failure of medical management. I have to put that out there. It's part of the continuum of what we do. It's not a failure of oral feeding. Some of us eat to live, some of us live to eat, and we have to find that happy medium. We also try to limit force feeding or forced eating, because what we're truly trying to do is make sure that meals remain pleasurable, that it's about exploring textures, flavors, it's about socialization, and we're really trying to prevent oral aversions. So tube feeding certainly does have a role to play. In terms of routes that we use, the nasogastric tube is usually the most common to begin with. You're basically bypassing the oropharynx or the head and neck, and you're feeding directly into the stomach. This avenue allows you to feed by bolus feed or by continuous feed, depending on what's best tolerated. Sometimes we'll use a combination where we do bolus feeds during the daytime and then we do continuous feeds overnight. This does not preclude oral feeds, so it is useful to a useful medium. Nasojejunal feeds actually, again, the tube goes in through the nose, but it goes past the stomach into the small intestine. The reservoir for food really is the stomach. We do transpyloric feeds when we think that there's issues with gastric emptying or volume tolerance in the stomach, or increased risk of vomiting and aspiration, for example. These are generally continuous feeds. They run over several hours. They may be run over 24 hours. We try to balance tolerance with how long we keep our patients on these feeds for in a 24-hour period. Some patients may tolerate 12 hours, 18 hours, 16 hours, but 24 hours, but we have to do what works for the patient and what works for the family and find that balance. The indications to move to a gastrostomy or a GJ tube or a jejunal tube are based on response to tube feeding as above, like NJ or NG. These are longer term tubes. When people ask me how long do these have to go in for, generally I say a minimum of 3 months to allow the stoma site to heal. And in changing from a G tube to a GJ tube, also you have to let that stoma be mature and heal, and that usually takes about 3 months. We try to do the least invasive method, and we try to go with gastric tubes or gastrostomy tubes as often as we can. GJ tubes do afford you the ability to have feeds in the stomach and beyond the stomach. But again, in theory, these things sound very good. In practicality, we sometimes run into issues with clogging of the tube, migration of the tube acting as a lead point for telescoping of the intestine or intussusception. So again, they're not perfect. Jejunal tubes, again, you're inserting a tube directly into the small intestine. In theory, again, these things work very well, but in practicality, you can have them as a lead point for that telescoping. They may be twisting, they may be torquing. So we try to do the least invasive and best tolerated approach that we can. In terms of duration of tube feeding, I know we talk about tube feeding as being open-ended, but it's not meant to be never-ending. The point of tube feeding is to be able to meet needs in a safe way. We don't want this to preclude oral feeding as long as it's safe. We want to continue to work on skills. People ask me about endpoints, and the endpoint is when you can meet your needs orally safely. I don't talk about time points as much because that's really a moving target. It's really based on your endpoints. So what happens if you have failure of medical management? If medical management is just not working for you, you're on all the medications, you've tried all the different ways of feeding and all the different formulas, you've tried the different appliances, your GJ tubes have been problematic, they keep kinking or they keep curling or they keep obstructing. Well, there is anti-reflux surgery that we sometimes think about, and that's one of the most common ones are the fundoplications. And really the indication is the inability to protect the airway from refluxate despite maximal medical management. And that includes prokinetics and then feeding in the stomach or past the stomach. These are often also considered pre-lung transplants. So patients with cystic fibrosis, for example, have fundoplications pretty frequently. It actually improves the outcomes of the transplant. Basically, what you do with the fundoplication is you take the fundus of the stomach, which is the upper part of the stomach where the stomach and the esophagus meet, and you bunch up that and you sort of bolster the lower esophageal sphincter region of the esophagus. What this does is it helps sort of bolster or reinforce an anti-reflux barrier. The issue with this procedure is that the pacemaker for the stomach is located in the fundus. It's not as focused or as concentrated as, say, a heart pacemaker is in terms of anatomy, but it is sort of in the fundus. And when you do a fundoplication, you actually disrupt that pacemaker function. The issues that you see with this in anywhere from 4 to 54% of patients, depending on the literature that you read, is you may have gas bloat, you may have dumping where you have dysregulation where the stomach empties very quickly, and you may have retching. The issues here are that you've reduced the volume of the stomach, and you've also impaired the accommodation reflex of the stomach, which is the ability for the stomach to accommodate more food. So for example, if you and I are eating and we want to finish what's on our plate, our stomachs can accommodate to expand that extra volume. After you have a fundoplication, that is impaired and you have not only reduced volume, but impaired gastric accommodation reflexes. You can partially compensate with these with venting. So with G-tubes, you can certainly vent fundoplication. So you can vent the gas out before feeds. If you're feeding transpylorically, you can vent the G-tube while you feed via the J. There are medications that may be able to restore some of this gastric accommodation reflex as well. So there are avenues for this. I think the skills and the qualifications of the surgeon are very important in looking at outcomes. And there's more than one type of fundoplication. So there's the Nissen fundoplication, which is the most common, but there's also one called the Thal and the Toupet, which have slightly different approaches. In terms of the issues post-fundoplication, most of these are transient. We can mostly manage around these. The volume limitation may be longer term. The disruption to the pacemaker certainly is longer term. So even if a fundoplication anatomically becomes undone, the damage to the pacemaker of the stomach may be longer term or permanent. Now, I believe that, there's not a single approach to feeding and swallowing disorders in children. I think you really need a multidisciplinary team to help advance your care. We put the patient in the center of this, but the aspects of feeding and swallowing that are important to us are there may be mechanical impediments with swallowing, say with patients with cerebral palsy, for example, or patients with upper esophageal sphincter dysfunction, as we've briefly discussed. There may be sensory issues where textures or flavors may pose more of a concern or a difficulty. There may be underlying medical conditions such as reflux, esophagitis, anatomical barriers. And then there certainly are behavioral aspects where you may have an aversion that develops to feeding that is actually takes quite a bit of effort to overcome. The underpinnings of all of this, of course, is nutrition. What are your goals? What do you want your patient's weight to be? What do you want their height to be? What do you want their BMI to be? What is associated with better health outcomes? So again, having a multidisciplinary team that puts the patient in the center of care, I think, is incredibly important. And several centers around the country, including ours, do provide for this. Similarly, I believe in multidisciplinary teams when it comes to managing aerodigestive disorders, where you may have dysphagia, aspiration, chronic lung disease, etc. The model that we use at CHOP, and we use it at other places as well nationally, include a partnership between GI, pulmonary, ENT, and speech to really get to where we need to in terms of our evaluations and management. So it really does take a village to move you forward. There are medical options, there are surgical options, but we do partner with families. We realize that feeding and swallowing are not static processes, they're dynamic, and they require constant reevaluation, reassessment, recalibration, and support. And we're here to sort of decrease disability and increase functionality, but we also recognize that we have to do all of this very safely to help keep patients safe, their families safe, and improve outcomes. I'd be happy to take any questions, and thank you for your time.
Hi, I'm Dr. Merchant. I'm a pediatric endocrinologist and geneticist at Children's National. Thank you for giving me the opportunity to talk to you all at SciFam regarding how do we optimize bone health. I'm going to start off with how this became a topic of interest for me over the years of training, and it's really started when I was a child. So I was born and grew up in Houston. I was diagnosed with this rare skeletal disease myself. I have a skeletal dysplasia. I'm only 3'6". I moved around the world, so I traveled quite a bit and had to figure out ways to get around. And I did my residency in Ohio, and then I spent 5 years at Texas Children's doing my genetics residency and pediatric endocrine fellowship. So I've got to see a wide variety of patients, but also different ways that in some ways you may be delivering healthcare and what may be priorities in different places. I'm currently faculty at Children's National. I work in the muscular dystrophy clinic as the endocrinologist there. I'm also in the bone health clinic, and I have a bone calcium clinic of my own. So to start off with, bone bank is built really early. It really starts from the day you're born. And you can't just wait for it to say, I'm going to start becoming active as much as I can and improve my bone density in different ways later. It's got to start now, because most of your bone density is built by the time you're 30, really by the time you end up puberty. And then from there, it's about maintaining that bone density that you already have. So the peak bone mass is really, as I said, in your 20s. And then, so you need to maximize it to its potential. Because if you have a chronic condition of any sort, or you have any other injuries that you've had of any, it's going to be lower than the peak that you would expect an average individual. But we can maximize it. And that's what our goal is. And that's what I'm going to talk to you about today. So how do I screen for bone health? I like to get a detailed history. So what's your diet? How many servings of calcium, milk, cheese, yogurt, dairy do you have in a day? What's your activity level? Do you walk? Are you in this, do you stand at stander? Do you do any kind of PT? Are you on any medications that may impact bones, such as steroids, anti-epileptics? And have you had any fractures, long bone fractures, or fractures of your hands, or spinal fractures of vertebrae? Those are all important questions, and I'll get to why. And then the next question is growth. Where are you in your growth? What stage of puberty? Are you starting late? Have you been through puberty? And what is your function itself that you have? And then labs, just want to make sure that your calcium is in the normal range, is your vitamin D level, and then also whether or not you have appropriate testosterone, estrogen. Really, have you gone through puberty or not? For girls, it's kind of an easy question. Are you having regular menstrual cycles or not? So when I think about disorders linked to bone fragility, I think about several different categories. So genetics could be just specifically to the bone, which is osteogenesis imperfecta, where the type of bone you're building is affected. Immobilization, so muscular dystrophies, which is why I'm here today. And then chronic diseases. So that could be like cystic fibrosis, where you have inflammation. And so for those families and patients, I'm like, you need to really control your flares that you have to improve the quality of your bones. And then there are other rheumatological conditions, eating disorders, and then there's what we consider osteotoxic medications, which are like steroids, anti-epileptics, that do have an impact on bone. Some of them we know how much compared to others, but in general, we do know they impact bone. So when we think about immobilization, we do know that the immobility alters bone geometry. This is even seen in patients who may have a spinal cord injury, for example, or a major accident of some sort that makes them immobile for a period of time, especially during their time when you're building most of your bone density. The type of bone that you're making is affected. So as I discussed, there are multiple threats to bone health, and that's what we're going to see if we can target any of these, or I can help you target these in different ways. So when I talk about the threats to like skeletal risk factors, I think of steroids, chronic disease, hormones and puberty, and then physical activity and vitamin D. I like to kind of draw this picture because I'm like 75 to 85% of your bone is related to your genetics. If you have a family history of fractures, hip bone fractures at a young age, any underlying genetic condition, I can't really change a lot of that, but I can try to impact the other categories that affect bone itself. So the question comes down to when should imaging be done? Because people are like, what is my bone density? Doesn't matter. DEXAs. I mean, if you're going to be starting steroids for treatment, we're not talking about Duchenne muscular dystrophy, but for Duchenne, I specifically like to get a DEXA before they start steroids to get a baseline so I know what happens and how the steroids affect their bones. If you're on treatment of some sort, like bisphosphonates, then I like to get roughly every year to 2 years because it affects whether or not I'm going to continue the treatment. And if measurements will change my management. So if you've had multiple bone fractures of some sort, then I may decide to do a treatment, and that's when I would want to get a DEXA. If you're having back pain, then I want a spine X-ray, or if you do happen to get a DEXA, then your BMDZ score, which is like your bone density scoring. If it's low, then you want to get a spine X-ray, and I'll explain a little bit why that's important. The nice thing about DEXA, it's fast, it's safe, it's available in most places, but it does matter where you get it done. You want to make sure and who's interpreting it. If you're getting a DEXA and then you're getting a repeat, you want to do it on the same machine in the same place if possible, because it can be a machine to machine can make a difference. There are reference data that we have that helps, but we don't really have it for each population, and we know that fractures can occur when you have good bone mineral density also. So it's not like we really know that if you have a poor bone mineral density that you're going to develop fractures, but it just gives you a little bit of an idea of maybe the quality of your bones and a quantitative, like a number to follow. But it's helpful, and it's one of the best tests I think that we have that's more readily available. There's a lot of other testing, but it's not as easily available. So how do we define osteoporosis in children? So the reason I mentioned if you have a low bone mineral density on your DEXA, or if you have back pain, you want to get a vertebral compression fracture. Because if you have vertebral compression fractures in a child, you definitely have osteoporosis and you meet the diagnosis. For on the DEXA scan itself, you have to have a low bone mineral density along with 2 long bone fractures by the age of 10 and 3 by the age of 19 to be considered to have osteoporosis. Otherwise, we just say low bone mineral density if it's just low DEXA. So how are we going to manage these? Well, if you're on steroids and you got to be on it, you got to be on it. But if you don't need to be on steroids, we try to take them off as soon as we can. Chronic disease itself, hormones, and puberty. If you haven't gone through puberty, that is something important. If you're not having regular periods, that's important to talk to your endocrinologist about, because those puberty hormones, testosterone, really does improve the bone mineral density. And then physical activity. It's the mechanosensors in their bone that say to tell your bones to make bone. And so activities like swimming don't put weight on your bones to be able to tell their bones to build bone. So if you are not as mobile, even spending time standing on a stander, doing physical activity as much as possible can help build bone mineral density. Just from like my experience, I've noticed that the kids that started being on a stander who are not immobile in some ways, that they had less likelihood of fractures compared to kids that did not. And there's some evidence of it in the literature, but really I think it goes a long way. And so that's something I really, really do stress, that if somehow you can do some weight bearing exercise or standing even for 30 minutes a day on and off, it doesn't have to be at the same time, it does go a long way. And then nutrition and diet. For some reason, people don't drink as much milk and dairy anymore. And so I always stress we need to eat high calcium food. Now there is calcium in other foods like broccoli but there is mostly the most amount of calcium is really in oat milk, almond milk, regular milk, and there is like cheese, yogurt. Some of them are fortified vitamin D or not. So you want to make sure your vitamin D level is appropriate. If there's not really any side effects of taking vitamin D, so I always say that if you need to take vitamin D over the counter. And then the calcium, I try to avoid calcium supplementation if I can, because it has a risk of kidney stones. And so I'd rather you take calcium in your diet through foods. There's a recommended calcium intake based on age in the diet. And then these are kind of just description of some foods. The reality is you only, by eating a little bit of broccoli, 45 grams, only 15 milligrams of calcium, versus 1 glass of milk has around 300 to 400 milligrams of calcium. And so that's why milk is where you're going to get more of your calcium than other foods. There is a lot of calcium in tofu, in also in sardines, but how much of that do we really eat and every day? So that's why I say we need to figure out, how do you get the amount of calcium you should be getting in your diet daily through foods you can eat every day, and get into that practice starting young and continue. An adequate vitamin D is anywhere from 600 to 2,000 international units, depending on what the need body, but based on how much time you spend in the sun, how much is in your diet, and also how much what your skin color, the darker skin color, the less vitamin D you make, in a sense, because that's why you may need more in supplementation. And so you may want to consider measuring it annually, because we're trying to maximize our bone health however way possible, in a sense. And then also the goal is to have it at least 20 to 30. So the prescription for activity, I titrate to every individual. We really need to figure out what works for you. What kind of ways can I have you do physical activity that will help? So PT is important. It's one way. And try weight bearing if possible. But we want to avoid immobilization, but also overuse, because if you overuse it, we also have an increased risk of fractures. And we want to recognize that there are risk of fractures. So even for some kids, I'd say with just moving the child or adult from one place to another is a risk of fracture. So I need stronger bone density so I can avoid that risk for fracture. And so that's why it starts as early as possible. There's when you, in a sense, the dose and response for activity. So we do know that as you are active, your bone density does increase. And so that's why I really recommend that you figure out, how do we increase our physical activity? And once you start being active, it does go up. And so we have to figure out how to do it in the best way possible, in the safest way possible. So as I talked about, there are a few options for drugs. There are parathyroid hormones that you would think would work, and growth hormone IGF-1, but really those are not options. The most is catabolic medications, which helps, and so estrogen, as I said, is really important for bone density. That's why I will ask the girls, have you started your periods? Have you, and how regular are they? And then bisphosphonates is what we were talking about, is a drug that helps decrease bone loss, but it's not a drug for everybody. We just don't give it to everybody. It really means that if you need it, we will give it. And also how many doses. We also don't want to increase the bone density too much, because that also increases the risk of fractures. So there has been benefits suggested in osteogenesis imperfecta and secondary osteoporosis, except in anorexia nervosa. But the limitation is mostly observational, uncontrolled studies in small cohorts. There's few studies that tell us like the endpoint, like what happens 10, 15 years down the road. There's never been a comparison between the different types of bisphosphonates. So like zometa versus pomidronate. And then there's also, we don't really do oral bisphosphonates in kids as much. It's not been as much well studied either. It's normally a infusion. And so really we reserve it to our patients with fragility fractures. It's there, it's a drug available, but it's not for everybody. And I don't give it unless I really meet the criteria for osteoporosis, or I'm almost certain that they're going to develop osteoporosis, which means that they have vertebral compression fractures, or they've had long bone fractures and a low bone mineral density. Can first fractures be prevented? The fracture risk is greater than 25 to 50% depending on the age. And once fractures occur, the increased risk of more fractures, it just increases. So prevention is the best treatment. So the main goal is, how do we improve the bone density as early as possible? So in conclusion, chronic illnesses and their therapies are risk factors for osteoporosis. Fractures are a major cause of morbidity. It also decreases your bone mineral density because you're not poor, you're not moving around as much for a while as you're healing. So I want to avoid fractures. And then there's major gaps that remain about optimal agent, dose, duration, and pharmacological therapy, and what does it really help in the long run. Bisphosphonates is not a silver bullet. People still have vertebral fractures despite getting pamidinate, Zol, Resinate, any of these drugs, but still a valuable, effective tool for those that we need it. So in conclusion, thank you for joining me today. And if you have any questions, feel free to reach out and think about your bone health. That's what I always say. And we can all think about it. So it doesn't start with just you, but your entire family. How can we be more active and be thinking about it every single day?